Yeah. Hello, everybody. It is a great Sunday evening. We are assembled in front of all of you online to discuss an important and a nuanced topic in the field of manometry. It is multimodal approaches to diagnosis and management of esophagogastric junction outflow obstruction, manometry, and beyond. So the talk will be delivered by Dr. Mayank Jain, consultant gastroenterologist from Chaitram Hospital, Indore. So, sir, we welcome, and it's a great privilege for us to have you here in this podium to share your expertise on this nuanced topic. As a part of Evolving Gastroenterologists Association, with the help of Reddish Talk, we have been conducting topics and discussions on nuanced topic in manometry and evolving fields in gastroenterology. It's a privilege for us to have you here to deliver this talk to us. Thank you, sir. Thank you for accepting the invitation.
Thank you, Prashanth, and thank you, Reddistock, for giving me this opportunity to present this interesting topic. Now, the topic assigned to me today is multimodal approaches to diagnosis and management of EGJ outflow obstruction, manometry, and beyond. So, this would be the outline of my talk. To begin with, EGJ outflow obstruction or esophagogastric junction outflow obstruction is a disorder of esophagogastric junction which is characterized by abnormal median IRP in both supine and upright position, more than 20% swallow showing intrabolus pressurization in supine position and not meeting the criteria for aplasia cardia. When these manometric abnormalities are associated with clinically relevant symptoms, mainly dysphagia and or non-cardiac chest pain, and at least one of the following abnormal investigations, that is timed barium esophagogram or FLIP, then we label it as clinically relevant EGJ outflow obstruction. Now, based on the manometry pattern that we see of the motility, EGJ outflow obstruction can have 4 subtypes. It can have EGJ outflow obstruction with spastic features, EGJ outflow obstruction with hypercontractile features, EGJ outflow obstruction with ineffective motility, and EGJ outflow obstruction with normal peristalsis. Now, EGJ outflow obstruction is a rare motility disorder. Western data shows that around 10 to 14% of patients undergoing manometry can have EGJ outflow obstruction. In India, the prevalence of this disorder is around 7.2% in patients undergoing manometry. It is commoner in females and usually occurs in 5th and 6th decades of life, and usually is divided into 2 common types: the functional type, where we cannot identify any cause, or the secondary type, where we have a definitive cause for EGJ outflow obstruction. So the secondary causes of EGJ outflow obstruction are multiple. They could be structural causes like hiatal hernia, stricture, rings, webs, diverticular, vascular compression, and gastric volvulus. Sometimes they could be post-surgical cases like post-fundoplication and post-bariatric surgery. Malignant disorders, mainly the EGJ, that is the gastroesophageal junction malignancies, and metastatic tumors can present with secondary EGJ outflow obstruction. Infiltrative disorders like scleroderma, eosinophilic esophagitis, and amyloidosis can also present with EGJ outflow obstruction. It is important to remember that certain medications like opiates and antipsychotic drugs lead to spasmodic contraction of the EGJ junction and can manifest with this manometric abnormality. Another important cause that we commonly encounter in clinical practice is measurement error, and in obese patients, we can get a secondary EGJ outflow obstruction, which usually improves in sitting position. That is why we usually have to do the test both in supine and upright positions. The symptoms, like in all esophageal diseases, are mainly 4 cardinal symptoms, that is dysphagia, chest pain, regurgitation, and heartburn. which can occur in varying frequencies. Different case reports have reported different frequency of symptoms, but it is important to remember that dysphagia and chest pain are the commonest symptoms of EGJ outflow obstruction. Sometimes patients may have atypical features like cough, globus, dyspepsia, hoarseness, bloating, hiccups, which can be present with these symptoms. And sometimes the disorder can be detected just incidentally because the patient has undergone a manometry for some other reason, but this disorder has been detected. So the diagnosis is basically based on manometry. So it's usually the manometry that alerts us to the suspicion of a diagnosis of EGJ outflow obstruction. In all these patients who are undergoing a manometry, most of the patients would have had an upper GI endoscopy. In upper GI endoscopy, we should look for structural causes. And if there are no structural causes, but the patient is presenting with history of dysphagia, we should take biopsies to rule out eosinophilic esophagitis. We all know that if a patient beyond the age of 55 years with a symptom duration of less than 1 year and weight loss of more than 10 kgs presents to us with history of dysphagia, we consider malignancy as the first clinical option. However, sometimes these patients can also harbor benign conditions like EGJ outflow obstruction and atlasia cardia, which are diagnosed usually on high-resolution manometry. Apart from this, endoscopic ultrasound and CT scan are helpful in assessing the esophageal wall thickness, but these modalities are not used in the current scenario. They are only used in case-to-case basis based on the further treatment that we are going to decide for the patient. Now we come to manometry. The entire diagnosis of EGJ outflow obstruction is based on manometric abnormalities. As I told you earlier, that in HREM, we look at elevated integrated relaxation pressure in upright and supine position, which is one of the most important things in diagnosis of EGJ outflow obstruction. The patient should have preserved peristalsis, should not meet the criteria of atlasia, and there should be intrabolus pressurization and more than 20% of swallows in supine position. However, it is important to remember that only isolated findings do not confirm a diagnosis of EGJ outflow obstruction. Apart from this, we can do certain supportive tests that can help us confirm our diagnosis of EGJ outflow obstruction. The first test is a rapid drink challenge. Now, in rapid drink challenge, we ask the patient to drink around 200 to 250 ml of water quickly using a straw within a minute or two, and we assess the changes that are happening in esophageal motility. So usually the IRP will be elevated by 8 or more millimeters of mercury with a panesophageal pressurization that helps us to identify a clinically significant EGJ outflow obstruction. It is important to remember that these measurements have been done on manoscan machine, and currently we do not have any normative data or changes in IRP using a water perfusion system. So maybe in future, we'll have standard criteria for how to do a rapid drink challenge in water perfusion system, but till then we follow whatever has been mentioned in international literature and do the rapid drink test accordingly. Sometimes, if the patient is reporting dysphagia only to solids, we can do a solid test swallow in which we give patient mini idlis or small pieces of breadcrumbs or even a biscuit, like a Parle-G biscuit, which helps us to determine whether the patient is having any supportive evidence of abnormality of EGJ outflow obstruction. So here, if the IRP is elevated to more than 25 on 2 occasions with solid swallows, we can label it as EGJ outflow obstruction. Certain tests like using inhaled amyl nitrite, which reduces the IRP pressure by more than 10 millimeters of mercury, are only used in research setting and are not being used in clinical practice. This is how we do a rapid drink challenge, and this is what kind of an image we will get in a water perfusion system. Now, when this test is done in a sitting position, we ask the patient to drink around 200 ml of water as fast as possible using a straw. Repetitive swallowing leads to inhibition of esophageal peristalsis, and profound relaxation of the ileus as is seen in the figure. This helps us to identify latent EGJ outflow obstruction. The next test that we do is a timed barium esophagogram. So as I told you earlier, for diagnosis of clinically significant EGJ outflow obstruction, we need manometric abnormality along with clinically relevant symptoms and evidence of failed esophageal clearance by any of the two tests, that is FLIP or time barium esophagogram. In India, we use time barium esophagogram because of its low cost. In this test, we ask the patient to drink around 100 to 250 ml of 45% weight by volume of barium sulfate in standing position, and images are taken at 1, 2, and 5 minutes in left posterior oblique position. It helps. Usually, there should be retention of contrast at 5 minutes, which suggests that there is an EGJ outflow pathology. If there is no pathology, the barium would be cleared of the esophagus within the first 2 minutes. If the barium column is more than 6 centimeters at 1 minute and more than 2 centimeters at 5 minutes, it favors achalasia cardia more than EGJ outflow obstruction. This has been finding in one of the studies. However, we do not have Indian data to substantiate it. So if there is impaired esophageal clearance on a time barium esophagogram at 5 minutes, it gives us a good supportive evidence as to the diagnosis of EGJ outflow obstruction. Now, FLIP or functional lumen imaging probe and panometry is an important test that is being used in the West. It acts as a useful complement to clarify the clinical significance of diagnosis of EGJ outflow obstruction based on esophageal high resolution manometry. So usually we measure something known as an EGJ-DI or distensibility index using FLIP probe. Now, if there is a reduced distensibility of the EGJ junction, then we can identify patients who are having EGJ outflow obstruction. And it also helps us in identifying patients who are likely to benefit from achalasia type therapy, especially POEM and Botox injection that we would be discussing later. So for the diagnostic part, we should remember for high resolution esophageal manometry, we require supine and upright IRP to be elevated. We need at least 20% of swallows to show intrabolus pressurization, and provocative test should be positive. Now, when this is mixed with clinically relevant symptoms and a supportive evidence in the form of time barium esophagogram showing impaired esophageal clearance or FLIP showing reduced EGJ junction distensibility, we diagnose this as a clinically significant EGJ outflow obstruction. So once we have confirmed a clinically significant EGJ outflow obstruction, we have to take action and treat the patient to the best of our ability. We must remember that a single abnormal manometry findings is usually a false alarm. Many times we find that patients have features of EGJ outflow obstruction in supine position, but as soon as we do the test in upright position, everything clears off. Sometimes the catheter has not passed across the EGJ junction properly, and we can get a false alarm that the patient is having EGJ outflow obstruction. So these things need to be taken into account, and we need to confirm a diagnosis of EGJ outflow obstruction based on all three parameters, and then decide the best management strategy for the patient. Next, we come to the treatment modalities and management of patients with EGJ outflow obstruction. Now, it is important to remember that many of these patients have symptoms because we are talking about clinically relevant or clinically significant EGJ outflow obstruction. So if the patients have symptoms, they need to be treated. However, in some cases, the patients may be asymptomatic and the finding may be detected just on clinical testing. And in those cases, we just wait and watch. Until unless the patient is symptomatic, we follow an expectant treatment course. That is, we do not do anything, wait for the symptoms to appear, and then treat it. Apart from this, if the patient is symptomatic, we have pharmacological agents, endoscopic therapies, and surgical myotomy that can be offered to these patients. I would be discussing each of the modality in a little detail. The data on the use of all these modalities is very, very scanty, even in world literature, because this is a rare motility disorder. So we'll try to find out how best we can treat these patients. Now, for patients who are having an idiopathic or functional EGJ outflow obstruction, it has been found that when we follow up these patients for a period of maybe 5 to 7 years, we observe a spontaneous resolution of symptoms in around 40% of patients. These disorders rarely progress to more serious or sinister motility disorders like achalasia cardia. However, in the patients in whom it progresses to achalasia cardia-like illness, the predictors of progression are unclear. So if a patient has a functional EGJ outflow obstruction but does not have really any symptoms, we should just observe the patient. And for patients with mild symptoms, pharmacological agents should be used. Various drugs have been tried in the management of EGJ outflow obstruction. These include proton pump inhibitors, calcium channel blockers, nitrates, muscle relaxants, tricyclic antidepressants, antispasmodics, peppermint oil, and acosciamide. Now, symptom relief in majority of these patients is poor. Around 40% of patients have symptomatic relief at the end of 6 months. However, whatever studies we have are on very small case numbers, and the current data on drug therapy remains weak. In my experience, I have used PPI, calcium channel blockers, nitrates, and acosciamide in patients with EGJ outflow obstruction with mild to moderate symptoms with good clinical response. Next, we come to botulinum toxin. Now, botulinum toxin is usually used in patients who are poor surgical candidates. It is one of the methods of treatment of achalasia cardia as well. So like achalasia cardia, here we have a motility disorder where the problem is mainly in the esophagogastric junction. So this is a low-risk intervention that offers good sustained relief in nearly 2/3 of patients above 6 months and a transient relief in nearly all patients. Now, FLIP comes into an important role in this modality. In the West, there have been studies where FLIP-enabled EGJ distensibility index has been measured, and it has been used as a guide to inject botulinum toxin to determine good symptomatic response. Botulinum toxin is usually injected in a dose of 25 units in all 4 quadrants in patients who are poor surgical candidates. Next, we come to dilatation, which can be done using through-the-scope dilators, pneumatic dilatation. Now, through-the-scope dilators have been used in some patients, but not found to be very useful. The response rate is around 30 to 35%. Pneumatic dilatation, like the one that is used in achalasia cardia, we go for a graded response where we start dilating initially with 30, and if there is poor response, then we go up to 35 ml. Usually for females, we go up to 30 ml, and for males, sometimes up to 35 ml. Usually, symptom relief is around 80% at the end of 5 years. And the risk of complications is usually low. Next, we come to POEM and surgical myotomy. Now, POEM and surgical myotomy are being used selectively in patients with EGJ dysfunction, mainly achalasia cardia, and that is how they have found a role even in management of patients with EGJ outflow obstruction. Now, POEM is a minimally invasive method of treatment, which is efficacious in non-achalasia motility disorders as well. The response rate is around 70 to 100% at more than 2 years. However, there can be problems like aspiration, pneumothorax, leak in the short term and reflux in the long term that can hamper the outcomes of POEM. We can also suggest robotic assisted and laparoscopic surgical myotomy in patients with EGJ outflow obstruction, and usually the response rates are very good. Up to 12 months data is available in a few trials, which suggests nearly 95 to 100% response. So we analyzed our data of 168 patients who presented to us with motor dysphagia with or without chest pain, and we did esophageal manometry in these patients. This was a retrospective analysis where we found that 12 of them had EGJ outflow obstruction manometrically. Now, the diagnosis was confirmed with clinically relevant symptoms, and we did a time barium esophagogram in all patients to find out whether their esophageal clearance was abnormal or not. The etiology of EGJ outflow obstruction in our patients was benign stricture in one patient, post-operative, mainly post-fundoplication in 5 patients, and functional or idiopathic in 6 patients. Now, mechanical treatment. For those having a mechanical obstruction, treatment of balloon dilatation was done, initially with through the scope balloon dilatation in 3 patients and pneumatic dilatation in the rest, and there was a good short-term response. In those who had a functional or idiopathic EGJ outflow obstruction, majority of the patients were obese, so they were suggested a weight loss program. They were started on PPI, acoshiamide was used, and there was a good short-term response at the end of 6 months. Majority of our patients presented with dysphagia as the predominant symptom. Chest pain was noted in 7 patients, and weight loss was seen in 3 patients. The median age at presentation was 42 years, and we found that males were more commonly having EGJ outflow obstruction compared to females. But since the number of patients is really small, we cannot make a generalized comment on this. Another important finding was that majority of the patients had a high IRP, and their DCI of the esophageal swallows was also high. That is, was in the normal range, suggesting most of the patients had an EGJ outflow obstruction with normal motility. You must remember that I had talked to you earlier about the 4 different varieties of EGJ outflow obstruction with different motility patterns. So majority of our patients in India probably have an EGJ outflow obstruction with normal motility. So treatment of EGJ outflow obstruction is primarily based on whether it's a functional or secondary EGJ outflow obstruction. For functional, if there are no symptoms, we just follow up the patient. If there are mild symptoms, drugs, as discussed earlier, can be used. In secondary causes, if there is an identifiable cause, it has to be treated to cure the patient of his clinical symptoms. Next, we have the treatment modality, which can be based on the symptoms of the patient. Usually, if there are no symptoms or mild symptoms, or an incidental finding has been made, we just need to wait and watch. If the symptoms are mild, we can wait and watch. If symptoms persist or worsen over a period of 6 months, we can repeat the workup and treat it. Some of the patients evolve into classical achalasia cardia, and then they can be managed according to the dictum of achalasia cardia. Next, we have if patients have significant symptoms and they have well-demonstrated obstruction on time barium esophagogram or FLIP. If they are poor surgical candidates, we can treat them with drugs or Botox injection, which has a good clinical response. And in good surgical candidates, we can go ahead with pneumatic dilatation, POEM, and surgical myotomy. So to conclude, EGJ outflow obstruction, the diagnosis requires manometry proof along with symptoms and at least one abnormal test, that is time barium esophagogram or FLIP. We should look for secondary causes and treat them. If there are asymptomatic or incidental cases, we should just wait and watch. Mild symptoms, drugs can be used. However, the current data is weak and we really do not know the efficacy of majority of the drugs in long term. It has been found that around 40% of patients do show clinical response to drugs, but the data remains very sketchy and weak. For patients who are symptomatic with obstructive features, good surgical candidates, we should go ahead with pneumatic dilatation, POEM, and myotomy. And poor surgical candidates, we can go ahead with drugs and Botox injection. So we should not treat EGJ outflow obstruction only based on manometry reports. It is very, very important. You have to have a multimodality approach to diagnosis and management of EGJ outflow obstruction. Look for clinically relevant symptoms and substantiate your findings with a time barium esophagogram. Indian data on diagnosis, treatment, and outcomes is very scanty. Hardly 1 or 2 studies have shown EGJ outflow obstruction. However, we do not have any significant Indian data on treatment and outcomes of EGJ outflow obstruction. Time barium esophagogram should be used by all of us in our clinical setting because it's a simple test that is available to all of us, and it shows that whether the esophageal emptying is normal or not. We should use POEM or myotomy even in non-achalasia motility disorders like EGJ outflow obstruction because of good outcomes that have been demonstrated in Western literature. And we need multicentric studies to confirm the diagnosis of EGJ outflow obstruction and its pathophysiology as well as prevalence in Indian circumstances. Thank you for your patient listening. Thank you.
Thank you, sir. That was a good talk and on a very topic which all of us feel is kind of not touched upon very frequently when we consider other topics like achalasia, jackhammer's esophagus, etc. So, of course, there will be a lot of questions when there is a very rare topic to discuss about and a lot of things to actually come up to the diagnosis. Apart from symptoms, manometry, again, even if you're doing manometry, we have to change and we have to do some provocative tests like change the position and then do a rapid drink challenge. And then we have to top it over with other supportive evidences from adjunctive tests like time barium swallow. We'll take up the questions right away, sir. So one of the first question is by a doctor from Indore. He has asked, what is the proposed pathophysiology of EGJ outflow obstruction in idiopathic cases and how does POEM help them?
So basic pathology or pathophysiology of functional or idiopathic EGJ outflow obstruction is unclear. Like in most cases, when we do not know the exact pathophysiology, we label it as idiopathic or functional. Probably it is a neurodegenerative disorder or probably a disorder of the musculature that is involved in the EGJ junction complex. Now, treatment is basically based on the assumption that your EGJ junction is not relaxing adequately to the food bolus that is coming down. So usually when you have a food bolus or a liquid, as it moves down the esophagus, the EGJ junction should relax and allow it to pass. Now, when this is not happening, like in achalasia cardia or disorders of EGJ junction, we need to treat it either surgically or with medications. So if the obstruction is significant, there is impairment of clearance, even on a timed barium esophagogram, then we usually go ahead for treatment with surgical procedures like a POEM or Heller's myotomy, like in achalasia cardia. So basically, the exact pathophysiology is still not clear. And as it's a very rare disorder, not much studies have been done on the pathophysiology. But I would like to say and add that some cases do progress to achalasia cardia. So probably it is something to do like what is happening with achalasia cardia. It's a neurodegenerative disorder and a disorder of musculature, probably secondary to some viral infections. We do not know the exact etiology for idiopathic as of now.
So, can we consider it like it is an isolated lower esophageal sphincter hypertension or a failure to relaxation at appropriate time as a probable physiological definition of IRP?
Probably, yeah. That sums it very well. So basically, it's a EGJ junction complex that is not relaxing to the food bolus. Now, whether it is associated with a normal motility, a hypermotility, or a hypomotility, it can be a different spectrum. So it's basically the EGJ junction that is not relaxing, and it can be associated with other motility issues, which would be a normal motility, hypomotility, or sometimes even a spastic contraction. So that is why we have different subtypes.
Okay, sir. When we have subtypes, like the 4 varieties which you have mentioned, sir, like does it translate to treatment in any form or it is just a manometric classification based on population data?
See, these findings have been reported by people who have worked on EGJ outflow obstruction. Even the Chicago group mentions it. But whether it really translates into clinically significant changes in the management is questionable. right now we treat in achalasia, we are treating the EGJ junction, not the motility part of the rest of the esophagus. So it would be not changing your treatment a lot.
Okay, cool. So the next question is by Dr. Ahmed Hasim. He would like to ask, in post-op dysphagia in fundoplication, your choice of dilatation or surgical option?
So if a patient has post-operative post-fundoplication dysphagia, so first and foremost, it is very important to demonstrate that there is a definitive impairment of esophageal clearance. That is very, very important. We need to document it very well. And treatment choice would depend on the patient. So usually if patient is willing to undergo another surgery, they can undergo a surgery. Otherwise, most of the patients prefer undergoing dilatation first. If there is no response, they go for surgery. So in my clinical practice, usually we go ahead with dilatation to begin with. And if patient is responding adequately well to dilatation and a surgery can be avoided, a redo surgery can be avoided, that's what we prefer. Otherwise, if even after dilatation, at least 3 sessions of dilatation, there is no good clinical response, then we go ahead for revision surgery.
Okay. Okay.
And another important thing is majority of these patients are referred by surgeons who have done the surgery. So usually it's the surgeon's call. If they are not happy with the type of surgery that has been done, they may even suggest for a redo surgery straight away.
Great, sir. Sir, well answered, sir. So, with respect to rapid drink challenge, when the patient is given a straw to suck as fast as possible the glass of water, what the IRP, if it is not less than 8, according to Manoscan, is considered as supportive diagnosis for EGJ outlet obstruction, isn't
Yes.
it? So
Yes.
my doubt is, if we have a validation study with the water perfusion system, would it change a lot, or what is the are there any studies going on, sir? Because there are enough studies which are done by you with a good decent number. So what did you feel? Are there any changes that we should look at?
Actually, see, the number of patients that we are seeing in EGJ outflow obstruction is really less. Okay, so we had around 13 patients in last so many years. We have just seen 13 patients with EGJ outflow obstruction. So really, I cannot comment on that. But I would like to think that more or less the IRP pressures would remain the same as described by Manoscan. Maybe a little bit change, plus minus 2 mm of mercury, but I think it would remain the same. That is what I personally feel.
Second, sir, timed barium swallow, when we do it, it was mentioned that more than 6 at 1 minute and more than 2 at 5th minute is actually suggestive more of achalasia. What would actually be seen in these patients if the timed barium is done?
So actually, when we are doing a time barium esophagogram, we looked at esophageal emptying. So for a normal person, the esophagus should be completely empty at the end of 2 minutes. Sometimes we even give a benefit of doubt and take up to 5 minutes as normal, thinking if there is a hypomotility disorder. But if there is retention of barium, even at the end of 5 minutes, it suggests that there is a disorder of EGJ junction, or the lower esophageal sphincter is not relaxing properly. Now, if the barium column is more than 2 centimeters, these are again studies done from the West, it indicates more of achalasia cardia in manometry compared to EGJ outflow obstruction. But we do not have any Indian validation studies on the same. So whatever we are following is according to Western data. So in our patients, 13 patients in whom we did time barium esophagogram, who was clinically suspected to have EGJ outflow obstruction, the barium column length varied from 1.5 to 5 centimeters at the end of 5 minutes. So it could be anything. So any abnormal, so we have not measured for our patients with achalasia. So I'm not really sure whether this cutoff really works for Indian patients, but this is suggestive of achalasia if the barium column is more than 2 centimeters. But in our patients, we found the barium column to be anywhere between 1.5 to 5 centimeters at the end of 5 minutes.
Thank you, sir. Sir, Dr. Aditya has a question. I have a case to discuss. 18-year women with 6-month dysphagia to solids and liquids, IRP 18.7, upright wet. Software says 22% swallows normal, 22% premature, but none look truly peristaltic on visual review. So it's an EGJ outlet obstruction with spastic features as per software, or should we label it as achalasia type 3? He has actually posted a picture there in the group chat if you are able to see it, and also has posted the barium swallow. Of course, we don't have the time of it, but yes, sir. Any comments on what you are seeing, sir? If you are able to open the chat box down there. Yes, sir. Chat box. Dr. Aditya. Yes.
So what he has described is actually there's what we can see in this one wet swallow that has been given to us is that EGJ junction is not relaxing properly. That is one important finding. Then, after the swallow has been initiated, there is a simultaneous contraction of a large, long length of the esophagus, starting from, say, 26 centimeters down up to 37, 38 centimeters. So there is a simultaneous contraction, which again favors something like a distal esophageal spasm. But since the EGJ junction is not relaxing properly, this may behave more like a type 3 achalasia rather than EGJ outflow obstruction. However, it can also be an EGJ outflow obstruction with spastic contractions, as we have described earlier. So sometimes it is important to remember that by manometry, we may not be able to classify these disorders very categorically. There may always be an overlap or a gray area where we are not able to distinguish between achalasia cardia and EGJ outflow obstruction. Even in world literature, cases have been described in patients who were initially diagnosed as EGJ outflow obstruction or distal esophageal spasm who progressed on to develop classical achalasia cardia. So the natural history of the disease would be very important. And all said and done, treatment options in both the cases would remain more or less the same. So if the patient is having significant clinical symptoms, there is impaired emptying, and we have definite evidence of EGJ non-relaxation on manometry, whether it is EGJ outflow obstruction or achalasia cardia, management would be on the same lines. Maybe if we just follow up this patient for 3 months or 6 months, we might find classical features of achalasia cardia. So probably this is a gray area or an overlapping feature. Even in the time barium esophagogram, though the time is not mentioned, I think in one of the x-rays we can see it as 11:39. I do not know the second x-ray, the time is not seen, but we can see that the barium is actually flowing into the stomach, but there is retention of barium. Whether this has been done at 5 minutes, I'm not sure. So if there is no retention of barium at 5 minutes, then the diagnosis of EGJ outflow obstruction would be non-confirmatory.
Okay. Sir, next question. With respect to pharmacological management, of so many options, how come acosia, sir? And how do you think it is actually helping these patients?
Yeah, so actually there are 2 or 3 studies on acosia, and because of its action of fundic relaxation, and anatomically the fundus and the EGJ junction remain quite close to each other. So there is a muscle relaxation happening in the EGJ junction as well, which leads to improvement in clinical symptoms. So that has been the proposed mechanism of using acosia in these patients. However, the studies are very few and limited. Hardly 8 to 10 patients have been started on acrostiamide with good clinical response. In our series, we treated 3 patients with acrostiamide with good clinical response. Majority of the patients incidentally respond very well to PPI. So like PPI, I think is the wonder drug for all patients with motility disorders, but it has to be taken in an adequate dose. So acrostiamide probably works because it's a fundic relaxation. It causes fundic relaxation, muscle relaxation, which might be affecting the EGJ junction as well.
Thank you, sir. Let me see if there are any questions. Okay, yeah. So Dr. Aditya has reaffirmed. So basically, important to remember that even one normal swallow rules out achalasia. From a peristalsis perspective, yes, 100% abnormal peristalsis.
Yes.
Here they would have the peristalsis per se is normal from the body, isn't it, sir?
Yes. So in achalasia, what you typically find is a mirror image contractions. You have completely failed motility, and you have mirror image contraction, one swallow followed by similar swallows, mirror image pattern that you will see in all types of achalasia, very, very classical. So, which you would not see in other motility disorders.
Sir, when we try to dissect different subsets of patients with EGJ outlet obstruction, what is that thing which segregates few patients as abnormal or normal after shifting to from a supine to sitting position? What are those few things, like say hiatus hernia or whatever could be the added reasons? Why does it become normal IRP if it's not EGJ outlet obstruction?
So basically, what people have found, either if it's a significant central obesity, if there's a hiatal hernia, and if your catheter has not been placed properly. These are the 3 major reasons that lead to normalization of IRP from supine to upright position. So first, whenever we are doing a study, we should be very careful and we should be 100% sure that the catheter has been placed properly or not. Secondly, if there is significant central obesity, the patient is wearing a very tight-fitting clothes, or the patient is having a significant hiatal hernia, sometimes the manometry probe can get coiled in supine position, which usually, as we are turning the patient or into upright position, it can straighten out, leading to correct measurements. So these are simple things that can happen, and in many cases that in supine, the patient has been reported to have a higher IRP, but in upright position, it is significantly lower. So basically, it's the positioning of the catheter that tends to play a role, as well as obesity and presence of hiatal hernia.
Cool, sir. Sir, Dr. Amol has a question. How much time we should try before going on to another therapy or poem? How much time we should try acrostiamide before going to another therapy or poem? That's what he meant.
Yeah, I would be very clear in that. If the symptoms are only mild, then we should go ahead with drug therapy. If the symptoms are severe, the patient is severely compromised, they have significant weight loss, then we should not try drug therapy. Okay, if the patient has symptoms with each and every meal, there is significant weight loss, significant dysphagia with chest pain, then maybe we should go ahead with a more definitive therapy. If the patient is a good candidate, go ahead with poem or surgical therapy or pneumatic dilatation. You can try pneumatic dilatation first with a 30 mm balloon, just to look for the clinical response. If there is recurrence of symptoms, then maybe you can go ahead with poem or surgical myotomy. Only if the symptoms are mild, we need to treat the patient with drug therapy. For severe symptoms, drug therapy is not indicated.
Sir, how many patients probably, when the numbers might be very low, that with time went on to evolve as achalasia or became completely normal? Or even if poem was required, probably the length of myotomy that is required might be very, very low, considering it's just a junctional problem. So any comment on this, sir?
So actually, in our subgroup of patients, the 13 patients that we studied, so actually in those patients, as you can see from the slide, if I can share the slide, majority of the patients had functional EGJ outflow obstruction and they had mild symptoms, so they were just treated with medications. And they had a good short-term response. We followed them up for 6 months in patients who had definite secondary cause, that is a mechanical cause. We went ahead with balloon dilatation, through the scope dilatation in 3 patients and pneumatic dilatation in 3. None of our patients have undergone POEM. So whatever I have quoted is actually whatever has been given in Western literature. None of our patients with EGJ outflow obstruction actually underwent a POEM. And patients who had secondary EGJ outflow obstruction, they all responded well to pneumatic dilatation or balloon dilatation. They were all secondary to actually fundoplication surgery.
Okay. Sir, with respect to other systemic causes, like where I'm just trying to fine tune if we are able to divide this other patient like esophageal, eosinophilic esophagitis presenting as some abnormality. Patients on opioids can sometimes have this kind of abnormalities. Patients with CTD can sometimes have these features. So, are all these also seen in clinical practice occasionally, and we have to rule this out before considering a definitive functional EGJ outlet obstruction?
Yeah, so the first and foremost, if any patient who is presenting with history of dysphagia has a normal upper GI endoscopy, we should take esophageal biopsies to rule out eosinophilic esophagitis. Now, eosinophilic esophagitis can mimic a lot of motility disorders, but treatment would be drug therapy. Okay, so we won't go for any surgical therapy or endoscopic therapy for these patients. Secondly, patients with connective tissue disorders, usually they have hypomotility disorders. So they can have something like absent contractility or ineffective motility, but additionally, they have a hypotensive LES. They'll never have an EGJ outflow obstruction. Very rarely, patients with SLE or scleroderma can present with achalasia. EGJ outflow obstruction has not been reported in any patient with connective tissue disorders till now, but very rarely, maybe less than 1 in 100 patients may present with achalasia, but that is because of complete muscle, what I would like to, extensive muscular involvement that can present with achalasia in such patients. But otherwise, it will be a hypotensive LES with hypomotility disorders. Okay. Regarding opiates, in India, we do not really see much of opiate consumption in our patients so that they present with clinically relevant symptoms. None of our patients that we have studied had significant opioid consumption. Very few patients who are on cancer treatment do present sometimes with opioid-related dysphagia. Now, in these patients, we just stop the drug, shift them to non-opioid drugs, and it leads to resolution of symptoms. So in India, we do not have a significant problem. Regarding eosinophilic esophagitis, as I told you earlier, we need to treat the eosinophilic esophagitis with different modalities of treatment rather than going and treating the motility part, which is just a manifestation of the mucosal or submucosal involvement or muscular involvement in these patients.
Thank you, sir. So we'll take one more question, considering we are almost reaching 1 hour's limit. So Dr. Aditya has asked, I had a patient who underwent Heller's myotomy with DOR fundoplication 2 years ago for achalasia type 1. She is now experiencing upper abdomen pain, reflux symptoms, and recurrent dysphagia. Repeat HRM shows absent contractility as expected. What would be the optimal next step in management in such scenario? Also, what are the guidelines? How frequently we should be doing TBE? He has posted a picture, sir, if you can go through. And yeah, is there any role of acosciamide in post-myotomy dysphagia? That's his question. If you can just show the picture, sir. Yeah, this is the picture. Post-fundoplication.
Yes. So actually in this picture, we can see that the lower esophageal sphincter or the EGJ junction pressures are actually low. So the surgery that has been done has been adequate. Usually if you're post-POEM or post-fundoplication, your LES pressures are below 10, that usually indicates that the surgery that has been done is actually good. So LES pressures are low, but there is a generalized failure of peristalsis. Now, patient probably is having dysphagia because of generalized failure of peristalsis. And in this condition, actually, cochiamide or any other drug may not be very, very helpful. So treatment in this patient would be first counseling the patient that the esophageal motility is not going to return to normal. And probably if this patient is having significant reflux, that can also sometimes present with dysphagia. Now, if the EGJ pressure is actually low and we do a 24-hour pH study and there is a significant reflux, then adding PPI would be useful in this patient. And second thing that we can do is a time barium esophagogram. There are actually no guidelines to suggest how frequently we should be doing a time barium esophagogram. But in this patient, because there is actually absent motility, the time barium esophagogram is bound to be abnormal. So probably we just need to counsel the patient. And secondly, we need to document that whether actually reflux is happening and whether reflux is the cause of the symptoms of this patient. So if reflux is really the cause of symptoms of this patient, then she can be treated very well with PPI that will resolve her symptoms of upper abdominal pain and dysphagia probably.
Great, sir. Thank you. We really had a confused idea about EGJ outlet obstruction, but now I feel that we have somehow tried to separate it out from other conditions. However, it's a branch, probably a topic which newer things could be added on, more validation to Indian population. Considering the rarity of the diagnosis, probably a talk like this, giving a brief discussion on the entire topic, right from pathophysiology, what are the different subtypes we could get, and what are the non-surgical or non-endoscopic invasive options that we have for mild symptoms, will really add a boost to our practice. Thank you, sir. Thank you for sharing this podium with all of us to describe.
Thank you so much.
Thank you
so much, Prashanth. Yeah, and I would like to say that, see, this is a very nascent experience that we have. We would like many people to come up and share their cases so that we have some data from India to really know how our patients are behaving. Now, this is a very rare motility disorder. Maybe all of us have seen 1 or 2 cases, 3 cases in our clinical practice, and we really do not know how to manage these patients. So whatever we discovered or found out is only on the course of our journey that we discovered that this is maybe one of the ways of treating this patient. So I would really thank ReadyStock for giving me this opportunity, and we had a nice, lively discussion. And maybe we can all group together and discuss such cases, which would improve all our clinical judgment and would help us in better management of our patients. Thank you so much.
Great, sir. That's a wonderful idea. We will take forward this idea of probably having more of a collection of data, because I would have seen 2 patients in last 2 years. So it was more like a discussion, like each of us would have had 1 or 2 cases over some time. So if we have a big unit of cases with proper data being collected, I think it itself would add on a lot of value. Maybe we can create a protocol of what all to be done and what all to be recorded, and have some uniformity in data collection. Definitely we will be able to contribute as much as possible from this particular subtype of topics. Definitely we'll consider that if we are able to go ahead with a good protocol.
And like I told in my presentation, I would advise everybody to start using time barium esophagogram in clinical practice. Just prime your radiologist. You just need 3 pictures clicked at 1, 2, and 5 minutes. It's a very, very useful test. We do not have flip available in India. So time barium esophagogram really makes your life much easier. You are able to show the patient that there is impaired relaxation and there is delayed clearance of the esophagus, and then we can go ahead with definitive treatment. So it's a simple test. We can all supplement our manometry findings. We'll also become wiser because sometimes we report it as EGJOO outflow obstruction and the barium turns out to be totally normal, suggesting that maybe something had gone wrong while we were doing the manometry. So it's a cross check for us.
Yes, sir.
So please start using it more frequently.
Thank you, sir. Thank you, sir. Thank you
Thank you so much.
joining us. Thank you.
Thank you.